what are the pertinent clinical history and focused clinical examination you will elicit in this particular patient. You will be very well aware that in the first slide we have given very limited clinical detail because this is like any ATLS scenario, because the patient has collapsed right in front of you with a bout of hematemesis. So you don't have any time to elicit any detailed history and clinical examination. So all you have had time is to go ahead and stabilize the patient, concentrating on the ABC. So you have sorted out the ABC. Now you have to take a step back. You are going to do the history and clinical examination. What are the focus history and clinical examination do in this particular patient? As far as history is concerned, you have to ask 5 questions. What are the 5 questions? You should ask history pertaining to bleeding and history pertaining to etiology, what has caused the bleed, and history pertaining to effects of the bleed, to what extent the bleeding has decompensated that particular patient, and what are the comorbids of that particular patient, and finally what is the medication history. So pertaining to bleeding, what are the questions we'll ask? Whether it is a hematemesis or bloodstained vomitus, whether is he having any jet black tarry stools, whether is he having any frank bleeding per rectum, whether it is hematemesis, whether it is melena, whether it is hematochezia. Why this bleeding, why this history is very important? Because your further evaluation will depend on what symptomatology the patient is having. Classically, you will differentiate your GA hemorrhage into upper GA hemorrhage and lower GA hemorrhage based on the ligament of Treves level. Upper GA hemorrhage can present as hematemesis and melena, and lower GA bleed can present as hematochezia. A small proportion of lower GA bleed can present as melena, especially the right colonic bleed. A small percentage of upper GA bleed can present as hematochezia, especially if there is a very high colonic motility. But why it is very important to differentiate? Because in case if it is upper GA bleed, it is stabilization and OGD scopy. If it is lower GA bleed, it is stabilization and CT angio bar colonoscopy. So that is why pertaining to bleeding, it is very important. And second thing, pertaining to bleeding, onset, when it is, whether it is acute or chronic. If it is acute, it indicates certain etiology. If it is chronic, it indicates certain other etiologies. And how many episodes are there? And whether it is association is cough. A lot of patients may mistakenly attribute hemoptysis with hematemesis. And coming to the cause, whether is there any history suggestive of acid peptic disease? What are the history you might ask? Whether is there any history of smoking? Whether is there any history of epigastric pain? Is there any history of dyspepsia? Is there any history of heartburn? Is there any history of chest discomfort? Any history of early satiety? It is history wise, you can't differentiate gastric ulcer versus duodenal ulcer. It is very tough to differentiate gastric ulcer versus duodenal ulcer. But these are the certain risk factors, and history wise you can pick up acid peptic disease. And you can ask history pertaining to chronic liver disease as well, like history of alcohol consumption, yellowish discoloration or jaundice, abdominal distension, hepatic encephalopathy like altered mental status, etc. So on and so forth. History suggestive of malignancy. What are the history could be suggestive of malignancy? It could be loss of appetite, loss of weight, anorexia, etc. Association, GA bleed association with severe retching and vomiting. Why this history is very important? Because we do have several unusual causes of upper GA bleed like Mallory-Weiss tears and Boyer-Have syndrome. And history of any vascular surgery, especially aortic surgeries. So this is pertaining to cause. You may have to elicit these histories. Pertaining to end organ dysfunction, because all these upper GA bleed patients will be having some degree of compensated or decompensated shock. So what are the end organ hypoperfusion these patients are having? History wise, they can have a palpitation, they can have decreased urine output, they can have lightheadedness, syncope or altered mental status, or they can have dyspnea. Coming to the next important history is the medication history.